Yeah, thank you very much. Wow. So it's a European Kidney Federation, Patients Federation, and we are about to start the meeting in terms of listening to presentations by Professor Raymond van Hulder and Professor Monica. Today we talk about the health education for kidney patients and the importance of shared decision-making in education, especially in early cases of CKD. So first of all, I'd like to introduce Professor Raymond van Hulder, and he will carry on with his presentation.
Okay, good afternoon, everybody. Thank you for asking me for this meeting. I think you're dealing with a very important topic, and I appreciate very much that you asked me to do this presentation. Do you have it all on your screen? Okay, then we can go ahead. So my topic is the need for health education in chronic kidney disease, and I give this presentation also on behalf of the European Kidney Health Alliance, which is a Brussels-based NGO that is defending the case of patients with kidney disease, and also of the nephrological community at the level of the European Union, and from there, top to bottom, also at the national level throughout Europe. And we are representing not only the physicians, but also the nurses, the foundations, and most importantly, the patients. Since a number of years, the European Kidney Patient Federation is one of our leading members, and we very much appreciate the collaboration, because I think to reach our aim, we need the support and the help of the patients, and together we are much stronger than as physicians only. Now, there are tremendous problems with the uptake of kidney treatment throughout Europe, and I give you an example of transplantation. Why do I give you this example? Well, because in end-stage kidney disease, it offers the best quality of life, the best survival, and the lowest societal cost. So one would expect that the uptake of transplantation throughout Europe is very high. But in fact, only 38% of Europeans with advanced chronic kidney disease is transplanted. And if you look on the right side to the graph, then you see that there are huge differences among countries. There are countries like Spain and the Netherlands that are doing very well, but there is at the other side of the spectrum, also EU countries that have a transplantation that is close to zero. So that means that there are many countries where there is a room of improvement. And one of the reasons why this uptake of transplantation is so low in some countries is in part due to the lack of information and education. I don't say that it's all education, but it's part of the problem. And if we look at the figures for peritoneal dialysis, it is exactly the same. Again, the same now, I think EU 27 countries, in between the UK dropped off. And here again, the quality of life is best, the societal cost is the lowest, and the survival is at least equal to that of in-center hemodialysis, but only 14% of Europeans on dialysis is treated at home. And again, a part of the solution to the problem is education. Because with European Kidney Health Alliance a few years ago, we undertook this inquiry among European kidney replacement therapy patients about their satisfaction on the information they obtained about peritoneal dialysis. And now this was done only in 7 countries. The red bars are illustrating the number of patients who are dissatisfied. So as you can see, overall, the average of dissatisfaction is about 35%, which is quite substantial. But on top of that, there are also huge differences among countries. And it will not be a surprise that the countries with the lowest satisfaction about the information they offer about peritoneal dialysis are also the countries with the lowest uptake of peritoneal dialysis. And you don't have to make yourself illusions. The results were similar for transplantation at large, for living donation, and they were even worse for home hemodialysis. So there is certainly an educational aspect that needs to be taken care of in this end-stage kidney disease phase. And here comes a study that was even more broad by De Jong and co-workers, that's emanating from the EDIT project, a European EU-sponsored project that was assessing the differences among countries in uptake of certain kidney replacement therapies, and also the reasons for this. And as you can see here in the blue boxes, there are the levels of no information received in percentages for home hemodialysis, peritoneal dialysis, and conservative treatment. Let's not forget that there is this third way of treating kidney replacement therapy, which is quite often overlooked in countries. And if you see at the overall averages for home hemodialysis, about 40% was not informed. For PD, it's also not very good. It's 25%, and for conservative, it's somewhere in between. What is even more interesting, I think, is also that there is a gradient among countries depending on their income. Here we subdivided the European countries in lower income, middle income, and higher income. Pay attention to the fact that it is lower income. It is, of course, not low-income countries, because within the EU there are no low-income countries, but they were just separated according to their income. And as you can see, for all three options, the lack of information is more prominent in the low-income countries than in the high-income countries. So there is also an economic factor. And therefore, I think, or we think that it is very important that the patients become resilient, and that they are clear in their communication with doctors, but also with policymakers, and that they become strong in telling what they want and what they would appreciate to be accomplished. And we found this very interesting initiative, and some of the members of the European Kidney Patient Federation already took part in it. That's EUPATI, and that is an education platform that increases patient engagement, and that is very interesting to follow to make up more resilience. But there is another problem, and that is that there is also this problem of health illiteracy. And this is quite prominent in chronic kidney disease. As a matter of fact, it's the same for many chronic diseases. But as you can see, this is a meta-analysis, so it made an average of several different countries. And you see that the level of health illiteracy here in the red circles is about 30 to 35% in CKD, not on kidney replacement therapy, and in CKD on dialysis. You see that the diamond here for transplantation is a little bit better, but that also points to another problem, that is that we have this kind of patient selection towards transplantation to have more the educated patients than not those educated. So we need also some form of education for specifically the health illiterate. And here I also would like to point to the fact that there is this other problem going together with it, which is an uptake of medication. Unfortunately, we don't have European data from the United States, which is, of course, a somewhat different health system and also socioeconomic system. It is clear that only about 50% of the chronic kidney disease patients are taking the appropriate medication, for instance, for preventing the progression of chronic kidney disease. So health illiteracy is a major problem. Health illiteracy in chronic kidney disease is affecting the outcomes. This is an American study using two different parameters, and in both there is an increased risk to die when health illiteracy is there. And therefore, we need specific education methods to reach out to these populations. Unfortunately, in our way of educating, we often are preaching for the church, and we are just reaching out to the ones that have already the information and that agree with the information. So we need specific techniques for the health illiterate, and we can only obtain those together with the patient community, with members of the communities where health illiteracy is high, and also with specialists in education, because we must admit that we as nephrologists are not really very well trained for education. And in this interesting study, they were looking at elements that were contributing to self-care, and they were scoring it for people with health illiteracy. And as you can see, the scores in any way are not brilliant. They have this level of 7 of 10 for a number of factors. But as you can see in the red box, the worst results were all related to quality of life, and to a number of quite easy preventive measures that cost nothing and that are able to have an impact on progression of kids. And as you can see, this is mainly related to diet, healthy diet, and above all to exercise. So exercise is really extremely unpopular among the health illiterate with chronic disease, and we need specific techniques to solve this problem. So lifestyle, and you know what it is about obesity, smoking, lack of exercise, salt intake, but also phosphate intake and sugar intake and calories. But I must also admit that it doesn't stop with patient education and information. We need also education of healthcare professionals. They need to be taught how to speak to the patients. There is a need for a creation of public awareness, because helping along the whole problem can only be done if the general population also is aware of chronic kidney disease, and at the same time also policymakers, so that the appropriate political measures can be taken. We have a need for benchmarking. That means that if information is given, we need to know whether it is given and what the quality is of the information given. We need policy incentives to steer the project. And finally, we are quite heavily in need of patient-friendly solutions. That is an aspect that has too much been forgotten over the last few years. This is it. Thank you very much for your attention.
Yeah, thank you, Raymond, for that. I hope everybody can hear me. We have had one question come in, and the question is, could you please share the source of the study about the percentage of health literacy?
Yes, but then I have to go back to my international reports. I will switch the light on here, but yeah, I will an answer to the question in the chat box.
Yeah, that
okay.
Then basically, if necessary, what we can do, we can always forward those answers back to the questions. If that's okay. Now, we haven't had any more questions yet, but it might be that everybody's absorbed the full information, etc. And no doubt we'll have more questions later. So I have asked just in case anybody else has got any more questions, but nothing's come yet. So we'll move on to Professor Monica, and if we can ask Monica to do her presentation, please, that'd be fantastic. Thank you.
Thank you, David. I hope you can see my screen. Thank you very much for your kind invitation. It's an honor to speak to you on the pre-dialysis education, although I would say pre-dialysis is only a part of education. Ray was touching upon that the education within kidney failure or kidney disease is very important throughout the disease. And I'm also going to talk about the shared decision making. So what really we as healthcare professionals need to do in order better educate, better inform, educate our patients. And when you look at the, yeah, can you see my slides? Can you?
Yes, we can see your slides, Monica.
Yep, okay. Because I can see here that sharing is paused, so I don't know whether you can see them. Okay, so with the trajectory of chronic kidney disease, we know that from mild to severe, it may take different amount of time. And it depends, of course, on particulars of kidney disease, but also it may depend on the treatment or adherence to diet, to medications, to the lifestyle indications. What Ray has just said, slowing the progression of the kidney failure is very important in the early stages of the kidney disease. And today I was asked to talk specifically dialysis, so the treatments or the choice of treatments for patients who enter the end-stage kidney disease. And what they have, what we have to offer would be transplantation, as Ray said, the best possible treatment, but not for everybody. Not everybody is eligible for that. Dialysis therapy, conservative treatment, and maybe palliative and supportive care. This decision map looks very complicated, but this just shows, and I will try to go through with you this through, just tries to show how many options our patients with end-stage kidney disease have. When you look at the failing kidney function from here to there, you know that you have many choices. It's not only the initial choice that you are making in terms of the option that you are choosing, but be even more choices. And well, later on, there will be the end of life treatment choice also. What do we have? What sort of pathways are to be chosen? Of course, transplant, maybe dialysis, and within dialysis, there would be home dialysis, there will be in-center dialysis, peritoneal dialysis, hemodialysis, and conservative care. Now, we have so many options. Why? Well, because we are very different. We may be young, we may be older, we may be fat, we may be thin. We have a lot of comorbidities, vascular disease or diabetes. We prefer sedentary lifestyle or be fond of sports. If we talk about elderly specifically, because this is the group of patients that majority enters treatments for end-stage kidney disease, for instance, dialysis. An elderly patient may also be very, very different. And we are not talking these days about the age specifically, but rather about fitness or frailty. And patient goals, obviously, because of that, may be very, very different. What is shared decision making? This is the key component of patient-centered or person-centered healthcare.
Can I just stop you for a minute? We've switched. We think your slides might be stuck. I don't know what slide number you think you're on, but we can only see the first one.
You have to go to full screen. You're still on your PowerPoint program.
Well, this is what I thought. Okay, let me do it again.
Technology, you see, it's all technology.
Yeah, let me do it again.
You can share again, Monica.
Can you see now?
Yeah, yeah.
Oh, the moving slides.
Yeah, fine.
Okay, I'm sorry for that. This is why I was asking, because it was shown on the screen that it might not be moving. So okay, so I will just briefly go through the slide that you haven't seen. This is the trajectory of chronic disease, and this is what I've just said, that from mild to severe it may take time, and it of course depends on the characteristics of the kidney disease, but also on the treatment, on adherence to the treatment, medications, diet, lifestyle indications, so on. And if we talk about education or training or information, we need to talk, as Ray has just said, about slowing the progression of kidney failure and talking about education early in the course of the kidney disease. But today I was asked to talk specifically about the end-stage kidney disease and the options like kidney transplantation, dialysis, conservative management, or palliative or supportive care. And with this decision map that you haven't seen, and which it shows to be a little bit too complicated. But when you look at slowly failing, I hope you can see my mouse moving, the choices of treatment will not only be initial choice, but also the choices throughout the disease and the end of life choice. And there are many options that can be chosen. Perhaps not everybody will be eligible, but transplant pathway, dialysis pathway within dialysis or in-center dialysis, and conservative care pathway are for patients to be chosen. Now, why so many options? This is what I've just said, because we are very different, young and old and fat and thin and liking sedentary lifestyle, and are fond of these who are fond of sports, and these with many comorbidities. So this makes the choice, well, is it more difficult? This is just because of that we have so many choices. When we talk about elderly people, this is what I just said, that we do not want to talk about age specifically, but rather about fitness or frailty, and that elderly patients may be very different. Their goals may be very, very different. And with shared decision-making, this is this process, this joint process in which healthcare professional works together with person to reach the decision. And the shared decision-making involves choosing whatever treatment, tests, medications based on both evidence and person's individual priorities, goals, and values. And the three essential elements of shared decision-making are, well, acknowledging that there is actually a decision that is required, knowing and understanding and being honest about all available evidence, and incorporating patient or person's values into this decision. This is what we call patient-centered vision of care, and really should do is ask this question: what treatment goals are attainable? What are the desired options for the patient? What do they want? And how can this be translated into medical care? Rather than asking ourselves, what do I have in my hands as an available option? This is the patient-centered care, not like in the picture. Now, when we talk about shared decision-making, this is all what is put into the circle. And what comes out really from it is that the impact on lifestyle and on quality of life is one of the most important things that would drive the choice of dialysis modality, conservative treatment, or whatever. For that, we would need to know a lot. And this is what Ray was. Health illiteracy is very high among countries like Europe. And what we would like to achieve is to diminish this Coleman gap of expectations on one hand and reality would increase further the quality of life. What actually about the reality? Are we realistic about the effects of treatment and the way we are talking to our patients? This is the example not from the kidney or nephrology field, but you can see that the cardiopulmonary resuscitation, as it is portrayed, for instance, and the reality is completely different. So we need to make it real. When we come again to these important decisions in terms of end-stage kidney disease, whether there will be kidney replacement conservative care, home therapies, or in-center dialysis. Well, on one hand, you need to for your patients to, or your people with end-stage kidney disease, to know the medical evidence. The medical evidence, like the example is here of peritoneal dialysis, what benefits, but of course, what are the disadvantages as well. When it goes to the elderly patients with the shorter lifespan, well, predicting the prognosis is also in our hands. We have the tools for predicting prognosis. So from the medical point of view, we do need to convey the evidence to our patients. On the other hand, we have to understand the patient's views on the treatments. And these are nice studies from the SONG initiatives that show that, for instance, in hemodialysis patients, when they were asked what they value most, they said ability to travel and dialysis-free time, while healthcare professionals were valuing more hospitalization rate, drop in blood pressure, vascular access problems. The same is with PD, that the patients value very much ability to live free life, fatigue, depression. Well, it doesn't mean that we are not, we are so in the, well, different directions, but we need to think that our goals, medical goals and or doctors' goals or healthcare professional goals and patient goals might be different. And we have to understand each other, and specifically when it comes to elderly people. I think I like this quote from Edwina Brown, who said that sometimes not every decision in life should be made with sole intention of prolonging survival, that the quality of life is important, and we cannot treat symptomatic treatment as a death sentence, right, as in this picture. There are challenges, and physician challenges are huge, and ethical issues. And I would say this is what I encounter in my country as well, that the renal replacement therapy options are not discussed widely. And why is that so? Sometimes because it is unavailable, sometimes because there are myths about this or that treatment. It's wrong. The patients should be honestly taught and informed about all possible options. We need to take into consideration, great consideration, patient preferences. But of course, the ethical issues still are there. Whether conservative kidney management, this is a no treatment, or maybe this is an active treatment or active management of symptoms. What is actually doing everything till the end of life? On the other hand, we have patient challenges, huge challenges, how to accept and cope with chronic condition, how to cope with the treatment and yet maintain the meaning of the life, how to confront my own mortality. And we know from the studies, and there are a lot of studies emerging from what patients think about it, that a lot of patients regret the decision of dialysis. That's so. What it's about is about the treatment options that they have. Our patients may have should have the treatment option, whether it is conventional transplantation and so on. We have to acknowledge palliative dialysis, so less dialysis, maybe better quality of life, of course, talking to the patient, and maybe sometimes vigorous symptomatic treatment. This is how it looks. Well, we choose the program in our washing machine, and maybe it's a little bit provocative, but the treatment should be individualized, individually good for an individual patient. So how to achieve this? How to achieve this, this getting a proper decision making? And I put two of my thoughts about that, that the patient get informal education from websites. They have their own views. They get biased views on things because they met fellow patients with complications on dialysis ward or on nephrology ward. They have friends with their own issues. They get the informations from healthcare professionals that may be biased because of myths and unavailability of the methods. So what should be the formal pre-dialysis education? Well, the formalized program that includes all options is done with understandable language, that there is an appropriate time, people, and place for this. And this should be done within every disease patient entering end-stage kidney disease, or maybe earlier. Well, a lot of my colleagues would say, well, I've informed my patient when he was in the clinic. Well, this sounds something like this, but this is not an education. The education is not opinion being conveyed or information. This is shared decision-making. So this is meeting two experts. I know the medical evidence and my patient knows what is important for him or for her. And with shows that there is trauma because we use not right terminology and patients get traumatized and they do not understand a lot. And of course, we know what should be the approach within the education, that the interpretive approach is the best one, but it requires significant time, training, comfort, discussing difficult topics, establish doctor-patient relationship, and the institutional support. An example from one study from Denmark, because we have all over the world, we have a lot of sort of educational programs for patients. And this one just shows 3 meetings when they talk about the choice, about the options, and about the decision. And they put here how many patients made the decision after 1 to first, second, and third meeting. It depends. I think we need, and this is what Ray was saying, we need to create the formalized program of education with shared decision-making. Because I want to stress or sum up in the summary, choosing treatments should be based on both on evidence and on patients or person's individual preferences. And this is throughout the course of the disease. This is not only in the initial phase. Shared decision-making and educational programs involving all, so healthcare professionals, owners, and families on another side should be ongoing and intervention and professional intervention. And the last one I think is the most important. The more patients know, the better. Then they ask questions. Patients' knowledge on disease trajectory and all options of management is the key to empower them to participate in seeking appropriate individual choice for everybody. Thank you.
Thank you very much, Monica. We do have a couple of questions, and that was an excellent talk and so interesting as well, listening about patient education. And I think, you know, from my point of view as a patient, I think it's got to be informed decision making, and I like to be informed of all my options, and then I can talk to my team and decide what the best way forward for me as an individual is. And I just love the slide with the washing machine, because I often look at that dial and think, what is the correct number to put it on? And I must admit, I do ask my wife sometimes. But anyway, there we go. So one of the first questions been asked, and open to both of you, you might know this, you might not. Has there ever been any studies or researchers in Poland on health literacy among patients of different stages of CKD?
Yeah, well, I don't know of any, unfortunately. So specifically, there were studies all over the world. We have a lot of studies that Ray was mentioning, but also in the States, there were studies on that. And it looks that, well, patients, even though they are on dialysis, they do not know anything about end-stage kidney failure. While I do not know about any studies in Poland. I think this was the question in my country, yes? David?
Raymond?
Yeah, I think I can follow this. I think, to my personal opinion, it's mainly studied in Australia and in the United States and in the UK. And there are some studies from the Netherlands, but in general, it's an aspect that is really very much neglected in Europe. And I think also a comparison among countries would be very interesting to do a study.
Yeah, absolutely. I can say in the UK, there was a very detailed study called ATOM, which looked at the literacy, health literacy, etc., on people being given transplantation, etc. So it was well found that the people with the lowest literacy level didn't seem to get offered the same choice of transplant compared to people with very high literacy levels, etc. And there was a lot of work done in the ATOM study. It's very interesting. We move on to another question. In your view, who is the best person or people to create, provide, and deliver education needed? Is it in partnership? Question mark. Raymond?
Yes, I think this is not an only doctor thing, if this is the question, or even that we doctors are not really the most suited persons to give education. I think this is in part a role for nurses. I think nurses are closer to the patient and also have other tools. And I think it's also a task for the patients themselves. I think somehow they need to guide each other. So therefore, I'm very much in favor of the current evolution with where the telemedicine and also all means with social media, etc., are playing a role. I don't say that social media are good for everything. Sometimes it's also quite a nasty tool. But on the other hand, it may be very helpful. But I think that patients really need to think how to organize themselves and to inform each other within their community. This can be done by webinars, discussion groups, whatsoever. But I think Monica will have also some interesting views on this.
Yeah, I think that, Ray, you are absolutely right, that we as doctors are not well trained into the communication and education, which is sad, I must say, because our patients, I think they want this from us, right, to discuss it with them. But from my perspective in my country, I know that a lot of doctors are very paternalistic, so they just share the information, that's it. And they do not really do the shared decision making. What I do with in my department, who is educating the patient, because I have the formal program of educating patients in the pre-dialysis sort of. Well, this is within the peritoneal dialysis unit, but this is the pre-dialysis education for patients on PD, on hemodialysis, on transplantation. This is what is done in part by a physician, by a nephrologist, but the main part is done by nurses. And I think they are perfect in it. Saying this, I don't want to say that doctors should not do it or we can skip this. Well, this is not our obligation. I think the doctors should be closer to patients because many patients, they want to ask questions. And well, it depends on how you organize your education clinic or whatever, how you call it. But as I say, nurses in my department are perfect and fantastic in teaching or doing the shared decision making, actually.
Yeah, brilliant. No questions, Greg.
Sorry, I would like to add something that is that I think therefore in the curriculum of medical professionals, whoever, doctors, nurses, this should be in the curriculum. And I think what we also learned from COVID is that there are specific ways to approach people who are hesitant to follow a certain direction. I don't say that everything is perfect. You will not convince the very hardcore anti-vaxxers, but some people who are not really decisive, they may be helped if appropriate tools needs to be or can be developed. So therefore, I think really we need also to have the advice of education specialists, because we are not education specialists. And then finally, I would like to come back to what I said at the end about benchmarking. In the Netherlands, there is some sort of program where they're looking at the patient information and at the quality of patient information. And again, although this is not a perfect tool, it may give some feedback to the doctors on how to improve things.
Yeah, brilliant. Thank you very much. So the next question. Renal replacement therapy patients have high rates of emotional distress, anxiety, depression, etc. What role does emotional coping and management play in the education of the
Now it's Monica
patients?
who has to start.
Can it be an important interference?
Yeah, well, I think these are the issues that are very rarely touched upon by nephrologists, right? Because these are the, well, we would say symptoms that are apart from kidney failure. But this is the main, and I would say very often the major problem. Specifically, well, at least from my experience, many patients go to the clinic with kidney disease and then kidney failure. And really, they are taking medications, they are talking about diets and so on, and nobody talks about the progression of the disease. And suddenly they realize the life is going to be changed completely. And it creates an emotional problem. So, well, I think within the sort of dialysis centers or clinics, chronic kidney disease clinics, there should be at least psychologists to help. Ray, what would you think about it? Sort of
yeah, absolutely. I think, but one of the problems, and it's really a serious confounder, and it's difficult to assess, is cognitive dysfunction, of course, as long as kidney function progresses, then also there are all kinds of neurotransmitters that are influencing the brain function. And probably once kidney disease is progressing, it's not necessarily health literacy that prevails, but all these other factors. Then we also have this kind of interference of age. There was a question about age, and age goes also along with cognitive dysfunction. And as we have an aging population with kidney disease, it's also a factor. And that is, of course, something that is difficult to manage. We need to be aware of it. So I guess that, I don't know if also in cancer treatment, this is a huge problem, although they don't have cognitive dysfunction, but then still, if the message is bad, they do not hear it at first instance. So this needs probably to be repeated. And again, it's a specific technique that we do not master very well, I think. But cognitive dysfunction by itself, we need to find solutions for it. It's a patient-oriented symptom. So that is something that we cannot cope with techniques. There we need to somehow sort out how it works and then treat it with removal or with medication.
Thank you very much. I'll just see if there's any more questions, but it doesn't appear there are at the moment. If there's any more, has anybody got any more questions to ask?
Maybe I would like to ask the question to Ray, if that's possible. Ray, well, you're doing fantastic work within the nephrology community and patients community and European community. Did you think about possibility of separately funding the educational programs for patients? That would be formalized, and that would be a must. Because I'm not sure how it happens in Belgium or in the Netherlands or in the different countries probably it depends on the center, whether they do have the pre-dialysis or education formalized. I mean formalized, not the information from the doctor or from the nurse to the patient. Whether there should be the formalized way of educating patients, the same way as well we have optional dialysis. We should have not an option, but the education for everybody.
Yes, I think I should look it up, but one of the problems with healthcare in Europe is that it's for the time being not a priority. So the Lisbon Treaty put it at some kind of secondary level. The consequence is that each European country has some sort of liberty to go in certain directions. This in some instances has been more or less coped with in part, for instance, in transplantation, because that's also a safety issue. But I'm not really aware where education stands. If it is it's a European priority. I'm not sure whether they can influence education, because I see that the educational systems in countries are also quite different. But on the other hand, they have a number of inter-European programs, and if you can bring together aspects and also bring together several different diseases, if you could take into the same basket diabetes and cardiovascular, and maybe also cancer, because cancer also is a big source of chronic kidney disease, or its treatment at least. It would help to convince the European Union, I think, to support this kind of programs, because there is a lot of money going around, but the problem is to find the right way to get it. And of course, the competition is tough, but it's certainly something we need to think about.
I have got one final question that just popped in. I said finally, it's just come. If you could give just one advice to improve the health education for kidney patients, what would that be?
I would say educate healthcare professionals.
Well, I would say the same. Educate the educator.
Okay, so it's
that's the patients can educate us. That's
I think a lovely simple question with a lovely simple answer, to be very fair. Yeah, so that's great. I've not seen any more questions, and I think at the moment I'd just like to say, Professor Raymond and Professor Monica, thank you very much for such an invigorating session, really, because I found it very interesting, and I think the education is so important for patients. But I also feel that patients need to take part as well. I think we all do. I do quite a bit of kidney school, as we call it in the UK, or transplant school, where we actually tell other patients what we feel what happens, because we do it, and patients really find that benefit. And I think we all need to make informed choices going forward. So I'd just like to say thank you very much for your time today, and on behalf of the EKPF and all its patients as well, all the patients, thank you very much. And I'd also like to thank everybody for attending and watching this presentation. I'd say thank you very much.
Okay, thank you.
Thank you very much. It was a pleasure.